hosted by the Gastro Foundation in association with Project ECHO and the University of New Mexico. We've had 60 registrations for this session from 15 different countries, and we're going to be talking about unusual presentations of HCC. Professor Jonas is going to give an overview, and then Nassim Mugler and Wanga Mtumkulu and myself are going to just present a few cases. So Professor Jonas is going to start.
Okay, I will share now. Thanks, Mark, for the introduction. Okay, so can you just tell me if you can see that?
Yes, we can.
Okay, great, thanks. Yeah, so as Mark said, the topic of today's presentation is unusual presentations of HCC. And just to start, just in general, how do patients with HCC present? I mean, we see these patients quite often, but you can divide it into two big groups. The one is symptomatic presentation versus screening and surveillance, and there's quite a big difference, as I will show you. See, if you look at patients with symptomatic presentation, we know that even in a patient with chronic liver disease, with cirrhosis, the onset of HCC on the background of cirrhosis may or not infrequently presents with worsening of the symptoms of and the signs of the actual cirrhosis. And that can present in many ways. It could be pruritus that becomes worse. The patient can clinically be jaundiced or more jaundiced than they usually are. They may present with a variceal bleed, and hepatic encephalopathy is not uncommon. Then you could look at systemic symptoms. These patients may present with weight loss or cachexia, and there are some other constitutional symptoms as well. Or it could be directly tumor related. Not infrequently pain, usually due to some form of a complication, but a HCC that is rapidly growing with involvement of the capsule of the liver can also present that way. And then in patients where there's worsening of the cirrhosis, and especially if there's infiltration of the tumor into the portal vein, where that element of portal hypertension is added due to obstruction of the portal vein, these patients can actually present with worsening abdominal distension. I think Mark has got an interesting case that will probably show that. So just the impact of screening and surveillance. This is just some data that comes out of the Swedish Liver Cancer Registry. So a very different situation from ours, but quite nice, reliable data due to their population-based registries. So they started with the introduction of screening and especially surveillance in 2010. And by 2011, it was actually nationally implemented. You can see there that there was between 2010 and 2019 a linear increase in the proportion of patients in whom the cancers were diagnosed with surveillance. So in 2010, there was a little bit of informal surveillance at that point, but the national program after the rollout, you can see that from 14.3% of patients that were diagnosed with surveillance pre the introduction of surveillance and screening, or screening and surveillance, to almost a third of patients in 2019. And I think that number has gone up since then as well. Why is this important? Because you can see in the next line there, in line with the number of cases that were diagnosed at screening, surveillance, that the proportion of patients in whom curative intended treatment was pursued increased from about 30% to almost 44%. And that 44% is a little bit higher than the envisaged number in the Barcelona criteria, where they aim to cure to offer patients curative intended treatment about 40%. And then also importantly, in the patients that had their cancers diagnosed at surveillance, almost 2/3 of them were treated with curative intent, compared to 25% in the non-surveillance group. So I know there's been controversy whether surveillance, screening and surveillance really makes a difference, but I think if properly done, these numbers would speak to that. What is the situation in sub-Saharan Africa? There are some particular characteristics of how the disease present in terms of the demographics and also symptomatology. We know that there's a male predominance, 8-1 in sub-Saharan Africa compared to 2.5-1 in non-African populations. These patients often present at a younger age, a range of about 33 to 47, 48% in sub-Saharan Africa versus 60 to 80% in non-African cohorts, more often associated with tumor-related symptoms. A large percentage of patients of the tumors in sub-Saharan Africa, or a larger percentage in the rest of the world, would occur in non-cirrhotic livers. And we know that the reason for that is that hepatitis B is still one of the major pathways to cancer. It's an oncogenic virus. So children or babies that get it at birth, somewhere around 20, 30 years, the virus often results in the absence of cirrhosis to HCC. The patients often present with larger tumors. There are some reports that report that the tumors grow more rapid. They more often present with complicated disease, rupture, usually following bleeding, and with a late detection, more often present with a metastatic disease. So if you look at the unusual presentations, and we're going to show you some examples of those today, they're either tumor-related in terms of the primary tumor, or metastases, usually that are detected in not so common organs but that they don't usually metastasize to. And there's also some cirrhosis-related complications that where you've got an HCC, the cirrhosis becomes worse and can actually give you complications per se. Just a number of examples of unusual presentations. You can see here a case report from Aga Khan in Kenya, it was, showing a patient that presented with, and you can almost clearly see here, the very normal liver, probably hepatitis B patient, and a tumor that started in the left liver and basically grew right through the abdominal wall into the subcutaneous tissue. About 5 years ago, I had the privilege to work a bit with the colleagues in Kenyatta Hospital, and I recall this case. It was similar. Young guy in his early 20s, very healthy and looking like it could be a soccer player, except for this bulge that he had on his abdomen. That's what he presented with. And again, you can see here a left-sided HCC that had grown through the abdominal wall around the ribs and was not salvageable with surgery. Just some other metastatic presentations. Bone metastases. Strangely enough, I thought that would have been more than 4.5%, but there's quite a large Chinese study that has shown that bone metastases occur in 4.5% of patients. The most common metastases or bones that are involved are the ribs. And you can see a picture here of a patient with a rib metastases that has grown from the rib to the size that you see there. Lumbar, thoracic, and sacral spine metastases are also common, and if the spinal column is affected by it, these patients present with neurological symptoms. Brain metastases also not that common. Some articles quote in the region of about 5 to 10%. Peritoneal metastases, I didn't put it there, but there's a study on a autopsy study that showed peritoneal metastases at about 3 to 4%. That I also thought is less than what we see. And then scalp and oral metastases. Most of these are case reports. You can see here metastases that presented with this large HCC metastases on the side of the face. That's all I had. Thanks, Mark. So I think we can just start going through the cases.
Thanks.
I'll just stop sharing here.
Just to, if anyone has any questions at any stage, if they can just raise their hand or just put the question in the chat, and we'll deal with it. So I'm not sure if there are any questions at this stage while Nasser loads his presentation. Doesn't look like it. Nasser, are you ready to share?
I'm going to share now, Mark.
Okay.
1 second. Can you see my presentation?
Yes.
Okay, sorry, just 1 second. Okay, thanks, Mark. I'm just going to go through a patient that we've seen in the last few weeks, which I think it was a rather interesting case. So the patient was 67-year-old, male patient. He was unemployed, previously worked as a farmer. He was living with his wife and a daughter, a heavy smoker, and he also had a significant alcohol use history. He smoked about more than 20 pack year history. He had no significant history of from a family history point of view, and he had a background history of hypertension and COPD. And he was on treatment for his hypertension and on inhalers for the COPD. He presented to the emergency department at our hospital with acute epigastric pain and shortness of breath. So he initially was assessed by the emergency team as having an MI based on his ECG with cardiogenic shock, and he was referred to the cardiology on-call, which they proceeded with echo, and they booked the patient for a CTPA because they were also concerned of possibility of PE. So no one at that stage, I think, examined the patient's abdomen, and he was we was taken for a scan, and after the CT scan and the echo, they observed some fluid in the abdomen, and I think at that stage they have just referred the patient to acute care surgery team, which they assist the patient, and on the abdominal exam they have observed that the abdomen was distended, it was tender, and he was the patient himself was quite sick. He was like acutely ill. So in terms of his bloods, so his Child-Pugh score was B7 and MELD score of 21. His blood HP was 8.4, white cell count of 36. And the rest of his blood showed that he had acute kidney injury, normal INR, and low albumin. His hepatitis screening was negative, and other than the strong alcohol history, he doesn't have any other risk factors for HCC. So I'm just going to go through the CT scan. So this was the arterial phase of the scan, and I think you can observe on the scan that the liver was irregular. There is like hypertrophy of the caudate lobe and hypertrophy or atrophic changes in the left hemiliver, mainly segment 2 and 3. And you can observe also that there was some fluid around the liver. And if I stop here at this level, you can see in segment 4, there was some like pedunculated, if I can say, or exophytic lesion from segment 4. Then on the portovenous phase, it was more obvious and it was clear that the patient had some fluid around the liver, and that lesion that we saw initially, it was more hyper-enhancing in this scan. Then the last scan is just a coronal view, which can also give us a clue about the amount of the fluid that was in the abdomen. You can see there was some fluid in the pelvis in both right and left paracolic gutter, and that lesion, you can see it here. Again, like obvious lesion. So what happened, I think, from here, after the patient was referred to acute care surgery, he was assessed as having an acute abdomen. They looked at the CT scan, and again, they didn't look to the lesion, and they thought there is most likely a perforation of some sort, maybe a perf du, because the patient abdomen started to become peritonitic. So they took the patient to theater. And the finding intra-op was like an HCC, we thought, on a background of a cirrhotic liver in segment 4B with the blood in the abdomen. So we first get called by the acute care surgery team intra-op, and that was the finding. The patient was on a small amount of adrenaline, but the anesthesia team were catching up, and he was improving, and his blood gases start to improve as well. His lactate start to drop from around 4.5 to 2.5. So I think at that stage, it was a quite difficult decision. And I think maybe we can put it on the table and see what everybody thinks. Should someone do a resection of that HCC, or maybe pack the lesion and come back, or maybe consider something like embolization? So I think there are multiple options which we might need to discuss. Then I'll tell you what we have done to our patient. Mark, up to you.
Thanks. I don't know if anyone wants to raise their hand, if anyone would offer a comment on what they would do in their hospital. Obviously, it does depend partly on what you have available, and if you have access to interventional radiology and embolization or not. So I think the options are pack, bring the patient back to theatre, and resect it later, resect it straight away, or potentially pack it, send the patient for embolization, and then bring the patient back to theatre and remove the packs later.
I think, Mark, also maybe if someone can look at the scan and you can appreciate that most likely there's something was happening, would you consider embolization from the beginning, or are you still going to take patient to theatre? Maybe
that's another good point. Yeah.
Mark, there's one other option. We can discuss through the different options and the merits of them here, and that is to, at operation, especially if you don't have an angiography suite and not embolization possibilities, and if the patient is bleeding actively and unstable, and you can't perform a resection, or it's just not the optimal time to ligate the right hepatic artery. That in this patient, that probably would also be an option. I just want to come back to the imaging first. So Nasser, you saw that the imaging characteristics were not completely typical for an HCC, in that it was not bright on the arterial phase. But I think one has to consider that it's a patient where there's been bleeding into the tumor before they rupture. That is what happens. They get an intratumoral bleed, and then it ruptures out to the abdomen. So there's usually some clot there that displaces some of the tumor tissue. And also, if this was hypotensive, that your arterial perfusion of the liver is compromised, like in the rest of the body. But if you go back to the portal venous phase, you can see a little bit of probably a rim enhancement there after what should have been a washout in the rest of the tumor. So just go a little bit further, somewhere around there, yeah.
So Ed, one comment. So I mean, I think ligation of the artery is potentially a good option if you don't have embolization available. I suppose someone who's not experienced in liver surgery, it might be problematic if the lesion's in the center of the liver, because you don't want to ligate both the right and the left artery. In this case, the lesion is in segment 4, and it could be getting its blood supply from both sides. So, I mean, I think if it's peripheral, like, on the extreme left or the extreme right, it might be easier to make that decision, but that might be a more difficult decision to make, especially if it's a big tumor in the middle of the liver. I don't know if you agree with me.
Mark, would you be worried in this like particular patient because his liver was like cirrhotic?
I think that's why embolization is nice, because it's more targeted potentially. So I think you'd have to factor in the patient's liver function. I mean, if the patient was really bad liver function, you'd probably be more concerned about ligating the artery. But you are in a situation here where it's a life-threatening bleed, and you need to do what you can to try and stop the bleeding. I don't see anyone with a raised hand, so people aren't volunteering what they would do.
Mark, I don't see it either. I can just see if we see somebody that we know. I don't know if there's anybody that want to volunteer. Otherwise, I see one of our ex-fellows, Dr. Miriam Khan, is on the meeting, and we can maybe ask her what she would have done.
Hi, Prof. Hi, everyone. I think being sort of at an academic hospital where you have access to interventional radiology, I think that would have been my sort of management.
Yes. So as definitive management, or would you come back later?
No, that would just be the sort of, in the event of the bleed with the cirrhotic liver, I probably wouldn't have done, try not to do sort of anything heroic, or wouldn't have offered anything surgical at that point.
So yeah, I think so. If you think about it, TACE is one of the ways we treat HCC. When you have a bleeding HCC like this, bland embolization is a really nice option. And I think if it gets diagnosed up front and you got it available, it's a really good option to consider up front. But in real life, it's not always available, and in real life, often general surgeons who don't see lots of HCCs manage these patients, as happened in this case, and they didn't appreciate what they were dealing with until they'd already opened the patient up.
Yeah, Mark, I just see there are some questions or comments in the chat. Any difference in the prognosis in HCC in cirrhosis versus de novo HCC?
So I'm not actually sure about that, but I think you do have a difference. I'm not sure if someone has compared like for like tumors in cirrhotic versus non-cirrhotic patients, but I do think you have potentially more treatment options available in non-cirrhotic patients, and we would often be able to resect more bigger tumors because the patient's non-cirrhotic. So I'm not sure if that answers the question, but resection is the first choice in patients with non-cirrhotic livers, and that's also the reason why HCCs occur at a younger age in patients in sub-Saharan Africa, because they're often associated with hepatitis B, and so it's the same reason why we see it in non-cirrhotic livers. We see it in younger patients because of hep B.
I think it's difficult, Mark. The factors are many, but there's at least anecdotal evidence that the HCCs in Africa, in especially young people, are more aggressive and metastasize earlier, are more often complicated. But I think there are a number of confounders there as well, that we in general diagnose patients very late, that they often present with, in the absence of screening, with symptomatic tumors. So I'm not sure how strong the evidence is, but the feeling is that in patients with non-cirrhotic livers, especially due to hepatitis B, that these tumors are more aggressive and probably have a worse prognosis.
Yeah.
Yeah. So
Right.
I think,
it says Wanga, NASA. Can you, so what, just say what was done.
Yeah, so I think we also had a discussion intra-op, and there are a few factors that helped us maybe to make a decision to go with a resection. And I think the one thing is the position of the lesion, which was like a superficial, and as I said, it was exovitic, pedunculated, easy to resect. And the other thing is the patient did respond quite well to the resuscitation and to the blood. And I think we thought the resection want to be a big resection, so we went with a resection, and I can share the picture here. So we did resect segment 4B and part of segment 5 with the gallbladder, and we thought that will give like a good control of the bleeding. You don't need to come back. And the other thing is he had oncological resection of that lesion, and the histology came back as T2 in note. And basically, you can say in X here. Yeah, so I think the patient post-operatively did it quite well, and he is due to come for a follow-up with us and the liver team, and he still need to have, or maybe he actually had G-scope for variceal surveillance by us.
So NASA, 2 comments. The one thing is, I think there's always a concern that you're going to develop, or could you develop sort of like peritoneal metastases now that it's ruptured, and that's always a concern, I think. The other thing that I found a little bit unusual about this case was I can't recall us having such a small HCC that's ruptured before. This was quite a small lesion, and it was very well situated to do a very easy sort of liver resection. So, I think in this situation, it actually turned out well. But I think often when you take a patient with a ruptured HCC to theatre, you're going to have a very big tumor that and require a big resection that's maybe not going to be possible. Yeah.
Nasser, just one other question. If you go back to the type 2 score and the MELD and the biochemistry of this patient. So if this patient was a
so I think his B7 was mainly because of the albumin, because his albumin level was quite low. So his albumin was 21 point something. And I think that's the reason that gave him the score of 7 on the child score.
So the question would be, so if this patient presented to you not with a complication, how you would have treated this patient, if you would have treated the patient the same?
Yeah, I think, Prof, I'd think, as we said, it's pedunculated. You can see it on the scan very clear as well, and it's a small lesion in a patient. Like, I think, yeah, I think I would still probably consider a small wedge resection for this patient.
I suppose the one thing you would be able to do differently is you could maybe try and do it laparoscopically.
Yeah. So you optimize a patient and
but I mean, potentially transplant would also be an option. And maybe, yeah. But I think in this situation, if it's resectable and the liver function is good, you'd probably go with resection.
Yeah, if someone's concerned about the liver function, then I think transplant would be the way to go. Yeah, I'm not sure what you think, Prof.
I see, sorry, this is one more question. Apart from tumor size, is there any other factors that predisposes to tumor rupture? I think it's an interesting question that I actually haven't thought so much about. As Mark said, that these tumors tend to be larger ones that bleed and rupture. But I suppose what also could be a factor is, as in this case, patient, that they are but it's very closely related to the surface of the liver. In other words,
I wonder if pedunculated ones are more likely to rupture. And then the other thing we discussed recently was pregnancy is often associated, if the patient's pregnant, is often associated with the rupture, but I'm not sure about other factors.
Okay. So if there are any other comments, please speak up or unmute yourself or put up your hand. Otherwise, I think, Mark, just in the interest of time, we should probably just move on to the next case.
I'll share my screen. I'm going to present a case now. Can you see that?
Yes, we can, Mark.
We can.
Okay. So the patient I'm going to present was a 32-year-old lady who initially presented with a variceal bleed, and was then diagnosed with Budd-Chiari syndrome, and was referred to the liver team here for assessment for management for that, and potentially for a transplant. At the time, she was noted to have an umbilical hernia and quite significant ascites that had come on quite quickly. The only history of note was that there was oral contraceptive use. She was started on furosemide, spironolactone, and albumin, and eventually there was a concern about spontaneous bacterial peritonitis, so she was on antibiotics. So while she was in hospital being worked up for the transplant, the surgeons were eventually consulted when the hernia actually ruptured, and you may know that's aptly called flood syndrome, and she started draining massive amounts of ascites through her umbilicus. So her performance status was good. Her Child-Pugh score was 8, and the MELT score of 10. You can see the blood results there, pretty good. Hep B, Hep C positive. The thrombophilia screen was negative, as is often the case in these patients, and the only predisposing factor for the Budd-Chiari syndrome that we could find was the oral contraceptive use. The alpha-fetoprotein was not elevated. So this is a picture of her umbilicus. You can see the skin breakdown and the necrosis. You can see the fluid draining. You can see quite a distended abdomen. So we took the patient to theatre, excised the necrotic skin. There was a small defect in the sheath that we repaired without a mesh, and you could maybe argue that was not the right thing to do. This defect was about 2 centimeters, so you can see we were placing interrupted, non-absorbable sutures. And I'm just going to show you the CT scan that was done at that stage. So first of all, I think what's quite impressive here, if you look in the area here, I'm not sure if you guys can see the pointer around the esophagus is the quite extensive varices. Then the other thing of note is that the vena cava sort of disappears, if you look here, as it goes through the liver, and you don't really see the hepatic veins draining into the liver, in keeping with Budd-Chiari syndrome. There was this this is a portal venous phase, and there was a hypervascular lesion on the right side of the liver that at this stage did not meet the criteria to be called an HCC. I think it was because it wasn't washing out. So it was noted to be a LIRAD 4 lesion. And at that stage, we sort of ignored that. But subsequently, that lesion grew, and it became clear that was an HCC. So just a few points on this. So umbilical hernias occur in about 20% of patients who have ascites due to portal hypertension. And we know that the complications of untreated hernias in these patients are strangulation, skin erosion, and ultimately rupture. In the past, mortality and recurrence rates were felt to be prohibitive, and a repair was only considered once there was a complication. I think there's now a feeling, especially in liver units, that early elective repair with optimal control of ascites is associated with the best outcome. And there was a randomized control trial that was done comparing upfront repair or early elective repair with conservative management. And once patients rupture, the mortality rates are as high as 80%. But having early elective repairs not without complications, and mortality rates can be as high as 10% in patients with ascites. So we know that refractory ascites is associated with poor wound healing, infection, and hernia recurrence. If the ascites is refractory to medical therapy, there are options. So you can consider TIPS if it's available, a Denver or Levine shunt. Surgery is generally considered to be contraindicated in patients with acute liver failure if there's acute viral or colic hepatitis, or if the Child-Pugh score is higher than 12. There's been a number of studies looking at the use of mesh in these patients, and it's been shown that the recurrence rates are lower if you use mesh, 3% in one study versus 15%. Obviously, the concern is the infection, the risk of infection, but that wasn't that high in a lot of the studies. So what we've tended to do is only put in mesh if the defect is bigger than 2 centimeters, and not that we see a lot of these patients, but in most of them, the defect in the sheath is quite small. So then the other thing, and I mean, it's rare to have an HCC and a ruptured umbilical hernia, but I think if you are faced with the situation and you realize it at the time, one needs to consider the life expectancy of the patient. And if it's an advanced HCC, then you really are going to be in a palliative situation. But if it's an early HCC, as it was in this case, you have all the treatment options available to you, and I think you need to then manage this on its merits. And then one also needs to bear in mind the sudden worsening of ascites or portal hypertension may be due to an HCC with portal vein invasion that suddenly increases the portal pressure and causes decompensation. So this is a little algorithm that I thought you could maybe argue could be used. So when a patient presents like this, you need to determine the etiology of the portal hypertension and liver disease. You need to ensure that they're on optimal medical therapy. This is for a patient with an umbilical hernia and ascites. If the ascites is refractory, options are TIPS, surgical shunt, a Denver Levine shunt, regular paracentesis would be an option if the hernia looked like it was about to rupture and the other options weren't available, and then also transplant. So if the ascites, or once the ascites is controlled, you need to assess the degree of liver function. And if the Child-Pugh score is below 12, then surgical repair is indicated, and you should probably use a mesh, especially if the defect is bigger than 2 centimeters. If the Child-Pugh score is more than 12, then you need to consider alternatives to surgery or transplant. This is a list of references that we used or that were used when that basically relate to this topic if you are interested in looking at any of them. Yeah, that's basically what I have to say on that. I don't know if there's any questions.
Thanks, Mark. I don't see questions in the link. Sorry, in the chat. Just one question, Mark. So in this patient, obviously it was a Budd-Chiari that makes it TIPS complicated. But if it hadn't been for that, say it was a patient just with cirrhosis, would you have considered tips in this
So-
patient before repairing in this specific patient?
I think once it's ruptured, your hand is sort of forced to do something because the ascites becomes infected, and the hepatorenal syndrome gets out of control because they're draining so much fluid. So I think a TIPS is indicated once you've done the repair. But I think ideally a TIP should be done before you get to the point where it ruptures. And then once you've controlled the ascites, then you should repair the umbilical hernia. So I think ideally in patients with lower than Child-Pugh 12, you should do everything you can to get the ascites under control and then fix the hernia. But your hand's forced once you get to the point of rupture. And like I said, the mortality rates in the literature are reported to be as high as 80%.
The surgical shunt, they are very, very seldom performed nowadays.
So, no, I just put that in there because I was thinking, in sub-Saharan Africa and in South Africa as well, TIPS is only available in very few centers. I mean, we are a transplant unit and we struggle to get TIPS done. So that's why I put that there. I think there might be selected cases where that might be an option, if that's the only way you can get the ascites under control. But I accept that that's not really something that would be possible in a lot of patients, but if you had ascites due to a portal vein thrombosis or something like that, maybe it would be an option.
No, I mean, they very seldom done. I can recall one the last 5 years that we've done.
Yeah.
And I think Dr. Khan actually took it out the other day because it got infected. You're
talking about so you're talking about the Denver Levine shunt.
I'm talking about Denver Levine shunts. Yeah.
Yeah. So I was thinking about a surgical shunt.
Oh,
no. I was talking about a surgical shunt as a potential option, but so I know about that case who had the Denver. Was it a Denver shunt? And I've never been involved in putting one in, but I think the technology's got a bit better. And I think in patients where TIPS is not an option or not available, but it's potentially something that can bide you some time. Yeah.
Because these things, the problem is that they eventually block. But if you only need a transient control of the ascites to be able to do a proper hernia operation, that's maybe something that one could look at.
Yeah.
Let me just see in the.
Mesh asked was asked how the patient's doing now. If you're asking about our patient, so that was actually this case was actually it was a while ago, and we ended up doing a TACE on that patient. And I haven't followed the patient up. The patient's been followed up in liver clinic, and because of this presentation, I went and looked, and I see that there's been imaging in 2022, and the patient was first managed in 2018. So they're still alive 4 years down the line, but I think there's still HCC present. It hasn't had a curative treatment with curative intent, just TACE.
Mark, just thanks. Just on I don't know if there are more comments about this or any questions. Nassif.
Hi guys, thanks very much for the fantastic presentation. I just have a question in terms of the repair of the umbilical hernia. Mark, you indicated that the recommendation is clearly umbilical hernias is very common in patients with chronic liver disease, portal hypertension, and ascites. We see it happen very frequently. Your recommendation was control of the ascites and early repair. But you also indicated that the mortality in that setting may be up to sort of 10%, which is quite high. I know it's a difficult situation, and if you leave it too late, you said the mortality may be up to 80%. What are the factors, in the advice, when should we be referring these patients? In those that have mortality up to 10%, what are the factors that obviously would impact a poorer outcome for the patient? Thanks again.
So it's interesting. I don't fix any hernias generally. The only hernias that I ever do are these umbilical hernias, and I do think there's quite a lot of the decision making is actually quite complex, and I think ideally these are not the type of things that should be managed by, I don't think, by general surgeons. I think it should be done in a liver unit ideally, and I think you have to factor each case in. So if you have irretractable ascites, let's say, and the patient's a transplant candidate, then it might be better to get the transplant done and then fix the hernia. If it's a young patient with good liver disease and you can get the ascites under control, then I think the hernia should be fixed once the ascites is under control. I think patients where you just can't get the ascites under control are the problem group, and those are the ones where you should maybe consider TIPS. But we don't do a lot of TIPS, but I think it's something that we should be doing more often, because if you get to the situation where you have a rupture, the mortality is so high. So I think if you can get the ascites under control and then fix the hernia, that's your best bet.
Yeah.
If you leave it and you get to a point where it ruptures, then you're in a really tricky situation.
Mark, I see there's a question from Abraham Malu. Will large volume TAP not control the ascites and allow for the repair long enough?
Yeah, so if TIPS is not an option, that is potentially your bailout. But I think the long-term recurrence rate is higher if you don't get the ascites under control. So you would, if you haven't done anything to control the ascites and the ascites is refractory to medical therapy, then that's what you're going to have to do around the time of the hernia repair.
Okay, thanks, Mark. Before we go on to the last one, I just, Neo Magico also just commented sent a comment that they had an unusual presentation with the HCC presentation that was published in the Ethiopian Journal of Health Sciences, and that was a liver abscess that had developed in the HCC. I suppose that is probably secondary infection due to central tumor necrosis. And I know we've had some issues after TACE where there was some probably infection or abscesses developing, but I can't recall that we've had one that presented.
De novo abscess.
Yeah. So that must also be one of the rare presentations that has to be added to the list. Thanks for that. All right, shall we move on to the last case?
Yes.
Wanga.
Thank you, Prof. Okay, I'm just going to present a very short case of one of the patients we saw in the past 2 weeks. One of the rare presentation of HCC. It's a lady that we received from one of our referring hospitals, a 33-year-old female who's known RVD on heart, well controlled with a CD4 count over 700, viral load lower than detectable. She's otherwise a healthy non-smoker, doesn't take alcohol, mother of one, she works. The patient had an ectopic pregnancy around end of May this year, operated at the referral center, and the histology showed HCC. Unfortunately, patient had not been able to follow up to the respective appointments due to social issues. At the time, when she was seen by the referring doctors, they'd done an alpha-fetoprotein, which was 4.5. And they also did an ultrasound at the point before the referral to us, which showed a normal, basically normal ultrasound, no liver lesions, normal size and normal echogenicity. Just to highlight the histology, did show that there was an ectopic pregnancy with free-lying chorionic villi. And then there was a separate tissue that was adherent to the ectopic pregnancy, which was about 2 centimeters in size. And it did confirm that it was HCC based on the stains that were done. So patient was sent to us based on that histology, and the histology was discussed with the histopathologist, and it given a confirmation that indeed it was a HCC. So when she came to us, about a month or so, 2 months or so from her initial presentation, she's still healthy, doesn't have any abdominal complaints, reasonable performance score. She's not jaundiced, doesn't have any stigmata of chronic liver disease. Abdomen was soft, no abdominal masses, no ascites. She's got normal functions, normal liver function. INR is normal with the albumin. That's also normal. Sorry, that was just typing error there, 8. Based on the fact, we calculated the child-poo score, which would have been 5 and the MELD of 6. When we did the hepatitis screening, she does have hepatitis surface antigen and the core antibodies that are positive. And alpha fetoprotein that we repeated 2 months later was 3, and other tumor markers were normal. Patient is still scheduled to receive a CT scan. That hasn't happened yet due to logistic reasons. As I mentioned, the patient does have some social circumstances honoring the appointment. So the question is now to open to discussion as to how this patient should be followed up further, and what sort of other management modalities one would do, or how this patient should be followed up. Because it does look like it was a complete resection on the specimen.
So it's very interesting that, so we're saying that there was, how do you explain it, Wanga? The fact that there was HCC in the fallopian tube?
One of the postulation, Mark, was a possibility of being from the fetus, but it does look like it wasn't. But we do know that HCC, very rare, far less than 1%. Sometimes we can get ectopic liver tissue that can present as a ectopic HCC.
So, and then just one other question from, you said the alpha fetoprotein was high at the time of...
The alpha fetoprotein was always normal.
So it's never been high. Okay.
It's never been high. Yes.
Okay. Right.
Wanga, if I may ask you, so the options, there are a few options here. Number one is that patient's got a HCC and it's a very, very strange metastases to the fallopian tube, or that the lab mixed up some specimens here and it's a contaminant, or that there is extrahepatic liver tissue sort of from before that underwent a malignant transformation, say on the basis of hepatitis B, because I suppose that hepatitis B will affect that liver tissue as well. So how are you going to exclude that this is not a contaminant?
Prof, it's quite a difficult one, but one would have to first exclude the primary cause to look at the liver, if there's no extrahepatic mets, to do proper imaging, CT scan, yeah, I think that is one point, and I think to get proper immunochemistry stains with discussion with the histopathologist probably is another way, which is what we've done. I'm not sure if there's any other way one can exclude that.
Well, I mean, there have been very few cases reported. There have been some reported in the literature, but I was just wondering if one should do some genetic testing on it to make sure that it is actually the tissue of the patient herself. It has, to my knowledge, not been done in any of the other case reporters where they've reported this. And what would also be interesting is to see if there's actually changes on the histology that could be related to, or if you, with some form of genetic testing, can see whether there's actually hepatitis B material inside that tumor. That would also be interesting. But a very interesting case. I don't know if there are any comments on that.
Just one thing also to note, the patient doesn't have active hepatitis B because the surface antigen was negative, but they've been exposed to hepatitis B in the past. Maybe it might just be worthwhile to do a viral load. Sometimes that can be positive even if the surface antigen is is negative. Was the patient treated? So the patient's on ARVs.
She's on heart, yes, and she was on
So-
treatment in prior
So
presentation.
maybe that's cleared the hepatitis B as well, and that might be why the surface antigen is now negative. So maybe there was chronic active hepatitis B, but I'm not sure that we can say that for sure, unless there was a record of that being checked before.
I was just thinking,
Yeah.
it came to my mind, I was thinking, what did the ovaries look like at that time? Because maybe there's sort of, I don't know if there are ovarian malignancies that sort of histology is quite similar to the staining.
This
know.
histology has been reviewed, Miriam. It's not
Yeah.
it's definitely not an ovarian tumor. It definitely looks like an HCC.
I mean, it's very interesting. I've never heard of that before.
Yeah, there are case reports. I must say I'd never heard of it either. Yeah.
Mark, there was just one more question from Neil that we maybe can respond before we conclude.
Yeah, I saw that.
Yeah.
So the question is about, is there a cutoff for size of resection of a HCC nodule? So there isn't a size cutoff. Like with most liver things, it comes down to the liver that you're leaving behind. So if you've got a non-cirrhotic liver, you can resect up to 70% of the liver. And if provided the liver remnant that you're going to leave behind is going to be adequately perfused and have good biliary drainage, then that's fine. In a cirrhotic liver, it's much more difficult to assess how much liver you can resect. But as a thumb suck, people say that if you Child-Pugh A and you don't have portal hypertension, you can resect up to half the liver. But that is, usually in cirrhotic patients, we'll just generally stick to wedge resections, and every now and then maybe do a little bit more. So I think you've got to worry more about the liver that you leave behind and not so much about the size of the lesion that you're going to take out. And sometimes you'll have like a pedunculated lesion hanging off the liver that's quite big that you can resect without having to resect much of the liver.
Mark, I was wondering if he doesn't refer to the guidelines as well, where there are some restrictions in terms of size. That if you really follow those, you're going to resect very few livers. So I think most liver resections that we perform are definitely outside something like the Barcelona criteria in terms of size.
Yeah, I must say, when I think about it, I don't even think about it. When I think of resection, for me, I know the Barcelona liver clinics have size limitations, but we know there's a lot of limitations to the Barcelona liver clinic staging system. And I think it really does come down to more what you're leaving behind, and just to be aware of the other treatment modalities that are available as well. Okay, so it's almost 12:30. I'm not sure if there are any other questions. If
in the chat.
Yeah, if there's not, I'd just like to thank everyone for joining, and thanks to ECHO and the University of New Mexico and the ECHO India team. There is a feedback form available in the chat. We would appreciate feedback. And the recordings are available on the Gastro Foundation website. Thank you to the Gastro Foundation, and thank you to the sponsors. Next week's GECO session is on inflammatory bowel disease. Thank you, everyone.
Thank you.
Thank you.